This recording will go over collection of urine specimens as well as lab and diagnostics for renal issues. Urine is analyzed for the number and types of organisms present. Symptoms of infection and unexplained bacteria in a urine specimen are indications for a urine culture and sensitivity testing, also known as a CNS. This CNS basically is a sample of the urine is taken and is taken to the lab, and the C stands for culture, and that's where we just figure out what type of infection the patient has, and the S stands for sensitivity, and that's where we find out what medication is effective for killing the infection or treating the infection. A clean catch or catheter-derived specimen is best for culture and sensitivity testing. Please see Table 65-3, which goes over nursing interventions and rationales for a collection of urine specimens. For a voided urine specimen, it's ideal to collect the first specimen in the morning. Send the specimen to the lab as soon as possible and refrigerate the specimen if a delay is unavoidable. Clean catch specimen you'll use frequently in the clinical setting. You want to make sure you understand the steps of this so that you can teach your patient how to do it properly. One thing I think most people know about the cleaning, how to clean, but review that if you don't. Frequently I hear myths is instruct the patient to initiate voiding after cleaning. The patient then stops and resumes voiding into the container. So they waste a little bit of urine to flush out that meatus and then stops and then actually starts the actual collection. Straight catheterizations can also be used to obtain a urine sample. It's the one-time passage of a urinary catheter. It may be necessary to obtain an uncontaminated specimen for analysis or to measure the volume of residual urine. Some urine collections are made for a specified numbers of hours, such as 24 hours, for precise analysis of urine levels of substances such as creatinine or urea, nitrogen, sodium, chloride, calcium, catecholamines, or other components. The urine collection may need to be refrigerated or stored on ice to prevent changes in the urine during the collection time. Follow the procedure from the lab for urine storage, including whether preservative needs to be added. The urine collection must be free from fecal contamination. Menstrual blood and toilet tissue also contaminate the specimen and can invalidate the results. The collection of all urine for a 24-hour period is often challenging. Please review Table 65-3 for 24-hour urine collection, nursing interventions, and rationales. So this, again, is another instance where we need to understand it completely and well in order to provide good teaching for our patients. So it's a 24-hour urine collection. On initiation of the collection, ask the patient to void, discard the urine, and note the time. If a Foley catheter is in use, empty the tubing and drainage bag at the start time and discard the urine. Collect all urine for the next 24 hours. So if my 24-hour urine collection is going to start at 8 a.m., at 8 a.m. I urinate and discard the urine, whether I urinate in the toilet or in whatever, and it gets thrown out, but it doesn't go into that 24-hour collection. So my 24-hour urine collection actually begins with an empty bladder, okay? 24 hours have passed. After 24 hours, ask the patient to empty the bladder and add that urine into the container. So I start my 24-hour collection at 8 a.m. on a Wednesday, and again, I empty my bladder into the toilet, and I'm starting my 24 hours at 8 a.m. with an empty bladder. I said Wednesday, right? So 8 a.m. on Thursday ends my 24-hour collection period. So at that time, I would urinate, empty my bladder as much as I could, and that urine would be added to the collection container. Do not remove urine from the collection container for other specimens. We also want to make sure that the patient has proper instructions about how to maintain the collection, whether it's in a refrigerator or on ice, or if a preservative is needed for the collection. Urine samples can be analyzed for electrolyte levels. Normally, the amount of sodium excreted in the urine is nearly equal to that consumed. Urine sodium levels of less than 10 indicate that the tubules are able to conserve or reabsorb sodium. Osmolarity measures the concentration of particles in a solution. The particles in urine contributing to osmolarity include electrolytes, glucose, urea, and creatinine. Urine osmolarity can vary from 50 to 1200 depending on the patient's hydration status and kidney function. With average fluid intake, the range for urine osmolarity is 300 to 900. Bladder scanners are used to screen for post-void residual volume, so how much urine is left in the bladder after the patient tries to urinate, and to determine the need for intermittent catheterization based on the amount of urine in the bladder rather than the time between catheterizations. In your textbook, you have a picture of a bladder scanner there if you're not familiar with one. Before scanning, you have to indicate or have to select either a male or female icon on the bladder scanner. What it really should have a picture of is a uterus, because that's what you're trying to figure out. If it's a female with a uterus, you would use the female icon. If it's a female without a uterus who's had a hysterectomy, or a male, then you would use the male icon. 2 readings are recommended for best accuracy. An aiming icon on the portable bladder scanner indicates whether the bladder image is centered on the crosshairs of the scan head. If the crosshairs on the aiming icon are not centered on the bladder, the measured volume may not be accurate. So it'll show a little blob of urine sort of when you're trying to do the bladder scan, and that indication of urine needs to be in those crosshairs for it to be a valid scan. You may hear of a KUB being ordered in the clinical setting. KUB stands for kidneys, ureters, and bladder, and it is an X-ray of the kidneys, ureters, and bladder. It can be used to screen for the presence of 2 kidneys, to measure kidney signs, and to detect gross obstruction in kidneys or urinary tract. A CT scan provides a 3-dimensional information about the kidneys, ureters, bladder, and surrounding tissue. Determine whether the scan requires contrast medium, often called dye. When contrast is used, ensure that there is sufficient oral or IV intake to dilute and excrete the contrast media. Typically, the radiologist will specify the total fluid intake of 1 liter or a variable rate to maintain urine output of 1 to 2 mLs per kilogram per hour for up to 6 hours. Contrast medium is potentially kidney damaging. Contrast-induced nephropathy is the onset of acute kidney failure within 48 hours after the administration of iodinated contrast medium. The risk for contrast-induced neuropathy is greatest in patients who are older or dehydrated, have pre-existing chronic kidney disease, or have comorbidities of diabetes, heart failure, or current hypotension. Patients who take nephrotoxic drugs are also at risk. Please review Chart 65-5 that goes over assessing the patient about to undergo a kidney test or procedure using contrast medium. Ask the patient if he or she is taking metformin. Metformin must be discontinued at least 24 hours before any study using contrast media and for 48 hours after. Patients taking metformin are at risk for lactic acidosis when they receive iodinated contrast media. MRIs provide improved imaging between normal and abnormal tissue in the renal system compared with a CT scan. They may be useful for staging cancers. An ultrasound can be used to identify urine volume in the bladder, the size of kidneys or obstructions in the kidneys or lower urinary tract, and can also assess blood flow to and from the kidneys. Inform the patient that ultrasound does not cause discomfort and is without risk. The test usually requires a full bladder. Ask the patient to drink 500 to 1,000 mLs of water if needed about 2 to 3 hours before the test to help fill the bladder. The patient should not void after drinking the water until the test is complete. A nuclear renal scan is used to examine the perfusion, function, and structure of the kidneys by the IV administration of a radioisotope. The isotope is eliminated 6 to 24 hours after the procedure. Encourage the patient to drink fluids to aid in excretion of the isotope. Because only tracer doses of radioisotopes are used, no precautions are needed related to radioactive exposure. Renal arteriography or angiography uses contrast medium to determine blood vessel size and abnormalities. Cystoscopy and cysurethropy are endoscopic procedures and require completion of a pre-op checklist and assigned informed consent. The tests are used to examine for bladder trauma, or urethral trauma, and to identify causes of urinary tract obstruction. Post-op, monitor for airway patency and breathing, changes in vital signs, including temp and changes in urinary output. Also observe for complications of bladder puncture, excessive bleeding, and infection. Bladder puncture is accompanied by severe pain, including abdominal pain, nausea, and vomiting. A catheter may or may not be present after cystoscopy. The patient without a catheter has urinary frequency as a result of irritation from the procedure. The urine may be pink tinged, but gross bleeding is not expected. Bleeding or the presence of clots may obstruct the catheter and decrease urine output. Monitor urine output and notify the urologist of obvious blood, clots, or decreased or absent urine output. Irrigate the Foley catheter with sterile saline if prescribed. Notify the urologist if the patient has fever, an elevated white blood cell count, which suggests infection. Urge the patient to take oral fluids to increase urine output, which helps to prevent clotting and reduces the burning sensation on urination. With avoiding cystourethrogram, the patient is requested to void and x-rays are taken during the voiding. Retrograde means going against the normal flow of urine. A retrograde examination of the ureters and pelvis, the bladder, and the urethra involves instilling a contrast medium into the lower urinary tract. This agent does not enter the bloodstream. After retrograde procedures, monitor the patient for infection caused by placing instruments in the urinary tract. Because the procedures are performed during cystoscopic examination, follow-up care is the same as that for cystoscopy, including monitoring for bladder puncture and perforation. Urodynamic studies examine the process of voiding and include tests of bladder capacity, pressure, and tone, studies of urethral pressure and urine flow, tests of perineal voluntary muscle function. These tests are often used along with voiding urographic or cystoscopic procedures to evaluate problems with urine flow and disorders of the lower urinary tract. Most kidney biopsies are performed percutaneously using ultrasound or CT guidance. Patient signs an informed consent and is NPO 4 to 6 hours before the procedure. Because of the risk of bleeding after the biopsy, coagulation studies such as platelet count, APTT, PT, and bleeding time are performed before surgery. Hypertension is aggressively managed before and after the procedure because high blood pressure can make stopping the bleeding after the biopsy more difficult. Uremia also increases the risk for bleeding, and dialysis may be prescribed before a biopsy. In percutaneous biopsy, the nephrologist or radiologist obtains tissue samples without an incision. After a percutaneous biopsy, the major risk is bleeding into the kidney or into the tissues external from the kidney at the biopsy site. For 24 hours after biopsy, monitor the dressing site, vital signs, urine output, H&H. Even if the dressing is dry and there is no hematoma, the patient could be bleeding from the site. An internal bleed is not readily visible, but is suspected with flank pain, decreasing blood pressure, decreasing urine output, or other signs of hypovolemia and shock. With severe bleeding, some patients develop bruising along the flank and back accompanied by pain. The patient follows a plan of strict bed rest, lying in a supine position with a back roll for additional support for 2 to 6 hours after the biopsy. The head of the bed may be elevated and the patient may resume oral intake of food and fluids. After bed rest, the patient may have limited bathroom privileges if there is no evidence of bleeding. Monitor for hematuria, the most common complication of kidney biopsy. This problem usually resolves without treatment within 48 to 72 hours after the biopsy, but it can persist for up to 2 to 3 weeks. The patient may have some local pain after the biopsy. If aching originates at the biopsy site and begins to radiate to the flank, back, or around the front of the abdomen, bleeding may have started or a hematoma is forming around the kidney. If bleeding occurs, IV fluid, packed red blood cells, or both may be needed to prevent shock. In general, a small amount of bleeding creates enough pressure to compress bleeding sites. This is called a tamponade effect. If tamponade does not occur and bleeding is extensive, surgery for hemostasis or even nephrectomy may be needed. If no bleeding occurs, the patient can resume general activity after 24 hours. Instruct him or her to avoid lifting heavy objects, exercising, or performing other strenuous activities for 1 to 2 weeks after the biopsy procedure. Driving may also be restricted. We'll go over these end of the PowerPoint questions here. You can pause the video and read them and pick out your answers. The correct answer for question 1 is D as in dog. The correct answer for question 2 is B as in boy. The correct answer for question 3 is D as in dog.